Tēnā koutou, ko Justin O'Sullivan toko ingoa, ko te manataki putahi ki Liggins, Liggins, ki Waipapa Tōmasaro. Tēnā koutou, tēnā tātou katoa. So welcome to our 25-year celebratory lecture this evening. It's on tiny babies, big questions, the high-stakes science of early nutrition. So in 1880, the French obstetrician Dr. Etienne Stéphane developed the first enclosed incubator for preterm babies. Apparently he got his inspiration from chickens at the zoo, which goes very well with the Liggins theme where work was done originally in sheep. But since then, advances in neonatal care mean that babies born earlier and smaller than ever before are now surviving. But survival was only the beginning of life. And over the past 25 years, work from the Liggins Institute has made major contributions to our understanding of the impacts of what happens in those very first days and weeks of life in these really premature babies. How this affects brain development and health and well-being, and how the impacts of that extend into later life. Tonight, we have the privilege of hearing how asking seemingly very simple questions, and often overlooked questions, like how quickly and how should we feed a baby? Does the smell or taste of milk make a difference to our development and health? How these questions are leading to discoveries that are changing neonatal practice here in New Zealand and internationally. The lecture tonight is a powerful reminder that careful scientific research can transform clinical care and improve the lives of thousands of children and their families. And tonight, we're privileged to hear from our clinical scientists who are actually doing this work. So first, Professor Frank Bloomfield, who is the acting Vice-Chancellor of the University of Auckland. I have to get this introduction right because he's my boss. Who was made an Officer of the New Zealand Order of Merit for his distinguished service to neonatology in 2024. And Frank is a world-leading neonatologist scientist whose research has advanced our understanding of fetal and newborn physiology, particularly around the impact of nutrition and growth on lifelong health. Tonight, Frank is being joined by Dr. Barbara Cormack. And Barbara is a specialist neonatal dietitian who also leads the clinical team of the paediatric dietitians at Starship Hospital. In addition to that, Barbara is a senior research fellow here at the Liggins Institute. As a neonatal dietitian, and internationally recognised researcher, Barbara's research has pioneered work on nutrition for extremely preterm infants that has directly changed clinical practice here and around the world. That's particularly through her research on refeeding syndrome. Frank and Barbara are also this evening joined by Dr. Tanith Alexander, and Tanith is a clinical neonatal dietitian at Counties Manukau Hospital, and she's an honorary senior research fellow here at the Liggins Institute. Tanith's research contributions explore the innovative approaches to improving outcomes for preterm babies. That includes the fascinating role that smell and taste may play in supporting development, reducing allergies, and strengthening the connection between babies and their whānau during their earliest days. For me, it's always a privilege to introduce speakers, but particularly clinical academics. What they can actually manage to do inside a 24-hour day is truly remarkable given their clinical activities. Sorry, I had lived that, but you could tell, So with that, look, I want to ask Frank to come forward to begin tonight's talks, and thank you, Frank.
Kia ora tātou, tēnā koe hanui, e mihi ana kia koe mō tō mihi karakia. So I'm really just the bookend this evening, and the meat of the presentations are going to be done by Barbara and Tanith, as Justin said. And both Barbara and Tanith did their PhDs here at the Liggins Institute. And the work they're going to talk about has arisen from those PhD studies, demonstrating the incredible attention to detail for which dietitians are renowned. So I'm going to just start off by talking a little bit about preterm birth, and apologies to those of you who are more expert in this area than I am, but I'm just going to set the scene very briefly. I thought I'd start just by asking the question, what is preterm birth? And that might sound simple, but it's actually not that simple in terms of how it's defined. It's defined as birth before 37 completed weeks of gestation, where full term being defined as between 37 and 42 weeks, with the average traditionally, historically, having been 40 weeks, although interestingly now in New Zealand it's actually only 39 weeks. So where did 37 weeks come from? Well, that's not very clear either. But in fact, if you look back through the literature, it really seems to have developed over time based on birth weight. And that's because, of course, the smaller babies were more vulnerable, less likely to survive, and also were less ready for birth. And that's where the term premature comes from. They were born prematurely before they were ready to survive. And there's a subtle distinction there between prematurity and preterm. Preterm being a statistical definition and before 37 weeks, but you can be premature after 37 weeks. You can be born at 38 weeks and still not be ready to be born at that time. The other important point I wanted to make is that preterm birth is a syndrome. It's not a disease. And it's the end result of many causes, which can be maternal, fetal, or placental in origin. And a fascinating thing about preterm birth is that in many cases, its origin lies at the very beginning of gestation. And so fetal growth and time of birth are often intricately linked. Preterm birth remains the major cause of mortality before the age of 5 years, and so is a significant global problem. Preterm birth, of course, has always been with us. Does anyone know who this is? No? This is Johannes Kepler, famous astronomer, who later in his life wrote that he was born at 224 days, 9 hours and 53 minutes of gestation. Presumably he worked that out from the alignment of the stars. Anyone know who this is? Absolutely. Come and collect a limited edition Liggins water bottle afterwards. Isaac Newton was born weighing 3 pounds, and it was said that he could fit into a quart pot. That's an English quart, of course, 2 English pints, which is about 1.14 litres, unlike the American quart, which is under a litre, being shortchanged by the Americans again. And this person? I haven't got enough for all of you, sorry. Winston Churchill was said to have been born 4 to 6 weeks early, but there's some debate about whether that's actually true or whether this just was said to hide the fact that he may have been conceived out of wedlock. And this one? Stevie Wonder. So Stevie Wonder was born in 1950 at 34 weeks of gestation, and his blindness is a consequence of one of the significant complications of preterm birth, in those days called retrolental fibroplasia, now called retinopathy of prematurity, and due often in those days to excess oxygen administration. Now these preterm babies were the lucky ones, because for all of that time your chances of survival if you're born preterm was extremely small. And really, it was only in following the birth of JFK's 4th child, Patrick Bouvier Kennedy, in August 1963, who died at about 33 hours of age, that interest in the US in supporting research into preterm birth really took off. And neonatology, the specialty looking after preterm babies, really only became established in the 1970s. The global burden of preterm birth is significant. You can see here that in 2020 there were 13.5 million babies born preterm around the world. A slight reduction from 2010, but it's important to note that's not a reduction in rate. It's a reduction because the total number of babies was fewer. And in fact, the rate around the world is about 10%. In New Zealand, it's about 7.8%, although in the mid-1980s, it was about 4.8%. And you can see that where births in the world are going up, the lilac at the bottom is sub-Saharan Africa, the numbers of preterm birth are also going up. And where the numbers are declining, it's where birth rate is declining. This graph shows you survival of babies admitted for neonatal care at National Women's from 1959 to 2023. Amazing collection of data. And you can see that between 1959 and the mid-1970s, the black line, which is babies born with a birth weight of less than 1 kilo, 1,000 grams, your chances of survival were not more than 10%. And it's really in the mid-1970s that survival started to improve, so that by now, if you're born less than 1,000 grams and admitted to a neonatal unit, you have approximately an 85% chance of survival. The earliest babies that are looked after today in New Zealand are around about 23 weeks of gestation, so 17 weeks early. In other parts of the world, babies are being cared for at 22 and even 21 weeks of gestation. But how do these really, really tiny babies do once they survive, if they survive? Well, we recently conducted a large randomized trial of nutrition in babies weighing less than 1,000 grams, which had neurodevelopment as the primary outcome at 2 years of age. We enrolled 434 babies across Australia and New Zealand, and as I say, initially measured the outcome at 2 years, but more recently, we've assessed the survivors at 6.5 years of age. The babies who were assessed at 6.5 years of age had a mean gestation of 25.5 weeks, 15 weeks early, mean birth weight of 780 grams. The proportion who survived to school age with no impairment whatsoever on standardized testing was 22%. The proportion who survived to school age with no or only mild impairment, defined as impairment between 1 and 2 standard deviations below the mean for example, an IQ test or needing spectacles or hearing aids, was 48%. So some of the issues that cause neurodevelopmental impairment in these babies relate to some of the consequences during the neonatal unit, such as sepsis, infection, physiological instability. Now, Barbara's going to talk a little bit about how some of the research that she did as part of her PhD and afterwards investigated some potential mechanisms that might be leading to poorer outcomes in these tiny babies. But most babies, as I referred to, are born moderate to late preterm, and more than 85% are born moderate to late preterm. And in this population, there is relatively little research. Moderate to late preterm refers to those babies born between 32 and less than 37 weeks of gestation. And of those, there are about 13.1 million babies born within that category every year. And yet there is very little research internationally either on how to care for these babies specifically, differently from the very preterm babies, or indeed on their long-term outcomes. So we recently completed the Diamond trial, which was another trial in this group of babies, which Barbara did Tanith did as part of her PhD, in which we trialled 3 different nutritional interventions in these babies, enrolling 532 babies in New Zealand. And you can see that taking international literature, even these babies have an increased risk of neurodevelopmental impairment. This graph shows you the risk difference on the y-axis for each week of gestation that you're born before 40 weeks, which is the reference here, the horizontal yellow line. And you can see that for every week, even between 37 and 40 weeks, which falls within the term window, you have an increased risk. So that if you're born at 32 weeks, you have a 6% increased risk over being born at term. In the big scheme of things, seeing as neurodevelopmental impairment is rare at term, this is still a relatively small number. This is not a large number of babies. For an individual baby, it's not a big risk. But because there are 13.1 million of these babies born around the world every year, that's a significant number of babies who are affected. And Tanith is going to tell us a little bit about possible ways of caring for these babies that might impact upon that risk. So how may we be able to improve outcome for babies born preterm? Well, we can think about what the potential factors might be, factors related to the underlying cause of preterm birth, factors related to being born preterm per se, or factors related to the care following birth. And that last one is what Barbara and Tanith are going to talk about today. So now I'm going to hand over to Barbara, who's going to talk about the role of refeeding syndrome in the outcome of preterm babies. Thanks, Barbara.
Thank you, Frank, and kia ora koutou. Refeeding syndrome has a very interesting and somewhat disturbing history. The first warning about it came from Hippocrates, the father of modern medicine, and he said a man who has been starving should not be fed immediately a full meal or he will die. As it turned out, that's quite good advice. The next documented description was from the Roman historian Josephus, who described the siege of Jerusalem in the 1st century AD. This was a siege that lasted over 5 months, and more than 1 million people died in the battle or starved to death as a result of the famine. Those who survived and fled to the Romans were described as being puffed up by famine and swelled like men with dropsy, and burst asunder when fed, which sounds rather unfortunate. And he also observed that those who were skillful enough to restrain their appetites and ate smaller meals did not die. He put the cause down to be greed and gluttony. Fast forward to the 20th century, and hunger and starvation marked the beginning of the 20th century, with blockades leading to mass starvation in both world wars and many reports of death in famine survivors when they were fed. For example, thousands of Japanese Imperial Army soldiers surrendered to US forces in the Philippines, and these men were extremely malnourished as a result of the army not feeding them and them having no food, as you can see from the man in that photo. And 20% of these men died when they were given nutrition. However, the cause of death remained a mystery. Also, in the Second World War, during the liberation of concentration camps, well-meaning soldiers gave survivors rich food and chocolate, which led to sudden, unexplained deaths within minutes or hours. And although this wasn't well documented at the time, it's been estimated that 25% of the people who survived the Bergen-Belsen concentration camp died within a few days of being rescued. The first scientific documentation of starvation was the Minnesota starvation experiment in 1944. So this was developed by the US government in an effort to try and work out how to manage the survivors of famine. And an American physiologist called Dr. Ancel Keys, who was working at the University of Minnesota, developed this experiment and ran it to simulate the conditions that prisoners of war would have been experiencing. So they got 36 conscientious objectives to volunteer to be starved for 6 months. This was a semi-starvation diet of about 1,600 to 1,800 calories, and these men lost about a quarter of their body weight. And that would probably be quite a mild form of starvation compared with what the prisoners of war experienced. But the key findings in this study were that starvation resulted in severe electrolyte imbalances, especially phosphate, problems with heart, muscle weakness, anemia, edema. But probably most importantly, they discovered that there were important psychological symptoms that were things like confusion, extreme apathy, loss of libido, and depression in the men. There were lots of experiments conducted on these men as they starved and were then rehabilitated, and this was all analysed and put together and published in a book called The Biology of Human Starvation in 1950. And although that wasn't quite in time for the war, there were preliminary findings that were beneficial for the Second World War survivors. This established the scientific understanding of refeeding syndrome and led to the guidelines that we use today for gradual feeding. Ancel Keys then went on to develop the Mediterranean diet, and he was also the man who developed K rations, so he had quite a lot going on. By the late 1960s, we had started to use parenteral nutrition to feed patients who were unable to eat or be fed with a nasogastric tube going up their nose and down into their stomach. So this parenteral nutrition, which is going straight into the bloodstream, was being used for adults and children, and this meant that we could give as much nutrition as we wanted to. We weren't limited by how much a person could eat or how much they could tolerate as a nasogastric feed. And so, of course, that didn't end well. In 1981, 2 American physicians published this paper, a landmark paper, describing 2 chronically malnourished patients, one of whom had anorexia nervosa, who appeared to be clinically stable, and however they died shortly after being started on parenteral nutrition. And this was the first time that the term refeeding syndrome was used. It was also about this time that we really began to understand the importance of phosphate in this picture. There are lots of different definitions of refeeding syndrome, but essentially it is a potentially life-threatening condition that occurs in malnourished individuals when nutrition is restored. It causes electrolyte imbalances, particularly for phosphate, potassium and calcium and magnesium, too little of the first three and high calcium in the bloodstream. And this leads to muscle dysfunction, lung muscle dysfunction, abnormal brain function, muscle weakness and abnormal heart rhythms. And the treatment is to gradually increase the nutrient intake and closely monitor blood electrolytes. We now know that a whole group of individuals are at risk of refeeding syndrome, and the hallmark of refeeding syndrome is too little phosphate in the bloodstream. Phosphate is a very important nutrient. A simple way to think about it is that it is a building block or a battery component for the body. It helps build bones, cells, and tissues, and it also helps every cell to generate the energy that it needs to function. It's found in every cell and required by every organ. And preterm babies have particularly high phosphate needs because they're rapidly building new tissues, bones, and organs. We don't really think of preterm babies as being malnourished when they're born, but if you look at the body composition of this little baby, you can see her bones showing through her skin and that she has very little in the way of nutritional stores. And that's because she's missed the third trimester of pregnancy when nutritional stores are transferred from the baby to the mother. No, from the mother to the baby. Just making sure you're listening. And babies like this may also have been exposed to maternal undernutrition or placental insufficiency, also limiting their nutrient intake. So Frank was talking about the PROVIDE trial earlier. Around the time that we were designing the PROVIDE trial, we started to wonder whether preterm babies might also be exposed to refeeding syndrome. And so we added some extra blood tests on day 5 after birth to investigate this. What we found was that 61% of the babies had hypophosphatemia, and for about 23%, that was severe, so a serum phosphate of less than 0.9. 20% of them had refeeding syndrome, which we defined as a low blood phosphate and a high blood calcium, a combination of the two. 15% died before discharge, which is not unexpected in a group of babies like this. And the proportion of babies who died before discharge that had refeeding syndrome in the first week was 43%. We also found that there was variation amongst the 6 hospitals in New Zealand in how many babies had refeeding syndrome and how many died. So you can see in Hospital D, 85% of the babies who died before discharge had refeeding syndrome, but in the hospital next to it, Hospital E, 33%. Hospital F, none of the babies who died had refeeding syndrome. And so differences in the number who had refeeding syndrome and also in the number who died. These differences were related to the composition of the IV nutrition solutions that the babies were having. We used standard solutions to give parenteral nutrition to preterm babies in New Zealand. And there were 5 different solutions being used in these 6 hospitals. Only 2 of them were using the same one, and that was Hospital A and Hospital F. We also found that the odds of refeeding syndrome decreased by 70% for each 1 extra millimole of phosphate per kilo per day we gave the babies in their nutrition. We also found that there were differences in clinical outcome. So twice as many babies who had refeeding syndrome had a severe brain bleed, although that was not significant, that p-value is not significant. For sepsis, that was higher in the babies who had refeeding syndrome, but again, that wasn't quite significant. But importantly, and when we looked at death before discharge, that was 3 times higher in the babies who'd had refeeding syndrome, and that was highly significant. We followed the babies up to 2 years corrected age, and we decided to see if there was any impact of their serum phosphate on day 5 and neurodisability at 2 years corrected age. So to do that, we divided the babies into 4 equal groups based on what their serum phosphate level was. And the babies in the lowest group had a serum phosphate less than 0.9, and that's the level that I previously called severe hypophosphatemia. And the babies in the highest group had a serum phosphate greater than 1.6. And what we did was to compare the bottom 3 groups with the top group and found that those who were in the lowest group had 3.5 times the odds of death or neurodisability at 2 years corrected age compared with those in the high phosphate group. And there's a dose-response relationship. You can see all of those dots are in a row, meaning that the more phosphate they had, the lower the chances of death or neurodisability. So we then went on to change our nutrition protocol in the hospitals. So this was in 2 hospitals, Auckland City Hospital and Middlemore Hospital. We changed the composition of the nutrition solutions to give more phosphate and calcium, primarily, in the first 3 days after birth. We talked to the Lab Plus about changing the lower limit of serum phosphate that was considered to be hypophosphatemia. So the previous limit was 1, and that's really a paediatric range for bigger children. And we managed to get them to increase that to 1.4. We started to monitor the serum phosphate level on days 3, 5, 7 and 14 for babies who are less than 1,000 grams. And if it was low, we gave them some oral phosphate supplements until it was back into the normal range. We then did another study. So in this study, we took some of the babies from the Provide cohort, the ones who were in Auckland City Hospital and Middlemore Hospital, and we compared those with a later cohort who had the new nutrition protocol and were born between 2020 and 2021 in the same 2 hospitals. So we've got 72 babies in the first group and 85 in the later group. And this data was collected and analysed by Thomas Wright, who's a Liggins Institute intern. And it was tricky because it was during COVID. And the characteristics of these 2 cohorts are very similar. And this shows their biochemistry on day 5. So we see now that in these 2 hospitals, 54% had hypophosphatemia in the Provide trial. And that went down to 21%. 12% had had refeeding syndrome, and that went down to 3%, and 11% had severe hypophosphatemia, and that went down to 1%. These were all significant differences. We also found that there was an improvement in neonatal outcomes. So this shows the difference in sepsis, culture-proven late-onset sepsis, 35% down to 22%, and probable late-onset sepsis, 63% down to 28%, both significantly different. So in summary, the change in intravenous nutrition protocol was associated with less hypophosphatemia, less refeeding syndrome and less sepsis. And other studies have now published similar findings to these. So in conclusion, the Provide trial is the first and largest multi-centred trial study to show that refeeding syndrome isn't just something that affects starving adults, it also affects our smallest, most vulnerable preterm babies. Importantly, we showed that it isn't just a laboratory finding, but is associated with serious illness, long-term neurodevelopment, and a higher risk of death. But the best part is what happened next. We translated this research to make very simple changes in how these babies were fed in the first few days after birth. Not with expensive new drugs or high-tech equipment, just getting the right nutrients to the right babies at the right time and monitoring them carefully. These discoveries have changed clinical practice throughout New Zealand and around the world, leading to improved outcomes. To me, this is what research at the Liggins Institute is all about. Taking a clinical problem, finding the evidence, and changing clinical practice to give the smallest babies a better chance, not just to survive, but to thrive. Thank you.
Tēnā koutou katoa. I'm going to change it up a little bit and talk about the power of smell and taste. So for those who don't know, I'm not going to quiz you like Frank did. This is Ivan Pavlov. He was a Russian physiologist that experiments took place in the late 1890s, early 1900s. And he was originally studying digestion and looking at how much saliva dogs produced in response to different types of food. And what he began to notice is that the dogs began to produce saliva when the lab assistant walked into the room with their food before they'd even seen it. And that made him question whether there could be learned associations and conditioned physiological responses. So he set up this relatively simple experiment whereby he rang a bell before the dogs received their food. So obviously, before they became conditioned, when they rang the bell, they produced no extra saliva. But with many attempts of the bell, then food, the bell, then food, the bell, then food, they learnt the association and began to produce saliva when the bell was rung, even though no food was given to them. And I know I only need to open the drawer in which my dog's food is kept, and he will come sprinting from wherever he is around the house. But what Pavlov actually won his Nobel Prize for was his work in digestion, and he pioneered surgical interventions in dogs where he could collect secretions from glands, long-term secretions from glands, and these fistulas that could do these sham feeding experiments. So basically, he would give the dog the food, they would get to taste it, to smell it, to swallow it, but before it reached the stomach, it would be diverted through a fistula and never actually reach it. And what he realized is that there was increased secretions even though the food had never reached the stomach. And that made him realize that the first stage of digestion was actually turned on by the brain. And this is called the cephalic phase response. Now here we have 3 photos: freshly baked bread, scones, and cookies. I want you to choose one that you think you would be most wanting to eat now. Then I want you all to close your eyes. I'm going to do a bit of an experiment. So close your eyes. I want you to imagine standing in your kitchen by the oven. It's nice and warm. You open the oven door and it wafts out the smell of either freshly baked bread, scones, or cookies. You take a deep breath in. You put it up on the stovetop. The aroma's filling the house. The guests arrive. They comment on how amazing the house smells. Maybe you can feel the saliva starting to produce more in your mouth, your stomach starting to rumble. Okay, you can open your eyes. So what I've done, hopefully, is, well, that's up to you if your imagination was good enough, is trigger your olfactory and cephalic phase response. So the olfactory system is the direct link between the smell and your brain. So when you smell something, it activates the olfactory nerve and it triggers the brain. There's also the cephalic phase response. So that might be the smell, the sight, the taste, and the thought of food, even the routine of food. So if you're someone who sits down every day at 12:30 to eat your lunch, you probably don't even need to look at your clock. At 12:30, your stomach will start to rumble and you'll know it's time for lunch. And basically that's a way for our body to tell us, or our brain to tell our body to prepare for that food, to get ready for digestion and to absorb the nutrients from that food. And our earliest smell and taste actually happens when we're in our mother's womb as a fetus. These fetuses are inhaling and swallowing the amniotic fluid, like in this. And babies can detect odours from 24 weeks gestation through their newly formed nostrils, and they can detect taste in the amniotic fluid, or flavours in the amniotic fluid, from about the 2nd trimester of pregnancy. And this is quite an interesting study done relatively recently in 2022 in Durham University that tried to look into this. So they investigated the fetus's response to different flavours. So they took 100 pregnant women whose babies at the time were between 32 and 36 weeks gestation, and the mothers either swallowed a capsule with carrot powder in it, kale powder, or a neutral capsule. And then they waited 20 minutes and they did these 4D ultrasounds to look at the baby's facial expressions, which freaks me out a little bit, those scans. So what they found is that the mothers that had taken the carrot capsule what they saw in their baby's facial expressions is it went from this neutral face to what they defined as a laughter face. So you can see the cheeks rise and the upturned mouth. In the mothers who swallowed the kale capsule, what their baby went from is a neutral to this cry face. And we've all seen babies do this. They drop their bottom lip and then they burst into tears. Just quite a cool experiment. So possibly the earliest, there's a direct link between amniotic fluid, what it smells and tastes like, and breast milk. And that's why newborn babies will prefer and recognise and transition to breast milk feeding. And if you place a term baby skin to skin directly after birth, they'll do this breast crawl. So they will move around using their sense of smell, because there's that sensory continuity between the amniotic fluid and the breast milk, also their sight and touch, and they'll locate the areola and initiate their first feed within an hour after birth. So thinking about everything I've told you about so far, and the importance of the body preparing itself for food using the brain, isn't it surprising that this is how we choose to feed our preterm babies? We insert tubes into their nose or their mouth that bypasses the sense of smell and taste, goes directly into their stomach, and then we do what this mum's doing in the photo, where we attach a syringe, pour milk into it, and that goes directly into the stomach. And so here at the Liggins Institute, we decided that that was something that we wanted to look into. And Frank's talked about the Diamond trial, but I'm just going to talk about the taste and smell arm of nutrition intervention. So we recruited babies to receive taste and smell or no taste and smell. And how we gave that intervention is we gave 0.2 mils of milk directly into the baby's mouth before a tube feed, and we placed a piece of cotton with milk on it next to the baby's nose that remained there throughout the feed. And we provided this intervention every time a baby got a tube feed throughout their neonatal admission. And so what we hypothesized is that by giving babies a taste and smell of milk, we would activate their cephalic phase response in their olfactory system, they would tolerate their food better, and they would reach full milk feeds faster. And after 5 years of recruitment and 532 babies, what did we find? No difference. So you don't need to be a statistician, those lines lie directly on top of each other. Regardless of whether the babies received taste and smell versus no taste and smell, they reached full milk feeds at around the same time, just under 6 days. But what we always planned to do was follow these babies up at 2 years, because in neonatal trials, making a difference to babies' short-term outcomes isn't as beneficial as we want to make a difference to their long-term outcomes. So we've got an internationally renowned follow-up team here at the Liggins Institute, headed by Dame Jane Harding, and this is a relatively old picture, so we might be missing some faces. But the follow-up team is extraordinary at building relationships and getting these whānau to come back for follow-up. So we brought these children back at 2 years corrected age, and we did a full neurodevelopmental assessment. So we looked at their cognitive, their language, and their motor development. And we also looked at their basic health outcomes. So what did we find? So for the full Diamond cohort at 2 years, we found that a quarter had developmental delay, almost all was mild. None were blind or deaf. 35% had doctor-diagnosed or treated allergies. Half of them had had infections needing antibiotics. 1 in 5 had low executive function, so that's your brain's ability to complete daily tasks, time management, things like that. And a quarter had behavioural difficulties. But how did it look when we looked at them by which group they were randomised? And this was a huge surprise to us and not something that we had fully expected. What we saw is that at 2 years corrected age, if those children had received taste and smell when they were in our neonatal units, they had 10% less neurosensory impairment, 10% less developmental delay, and 10% less language delay. And there was no difference in cognitive motor delay or cerebral palsy. But why? Why would we see better neurodevelopmental outcomes? So there's two possible, well, there's probably more, but I've got two possible hypotheses. The first is that by giving babies a taste and smell of milk, we've activated their cephalic phase response in the olfactory system. That's increased their neural pathways, increased their brain activity and stimulation, and improved their developmental outcomes. And we know from near-infrared spectroscopy studies where you place a probe on the forehead and you can measure the oxygenation in the brain, that there's increased oxygenation with different odour stimuli. The other theory is that depending on how big the babies were, if they were a bit littler, we would have fed them every 2 hours. So that's 12 times a day. If they were a bit bigger, we would have fed them 3 hourly, which is 8 times a day. So that means 8 to 12 times a day, either a parent or a nurse was interacting with that baby. They were providing the smell and taste, hopefully talking to the baby. And we know that language is extremely important for brain development. That's why we encourage our parents to talk to their babies, to sing to their babies, to read to their babies. So perhaps just having that increased interaction may have increased their brain activity and improved their neurodevelopmental outcomes. The other thing that we were surprised to find is that the allergy at 2 years corrected age was 11% less in the children that had received the taste and smell. And again, I have two possible outcomes. It could be early immune learning, so also called oral tolerance. So perhaps by giving babies small amounts of milk often, in small, calm, repeated exposures, the immune system learns to not respond as if it's dangerous and to respond, and so later on, food allergies are less likely to be triggered. The second theory is that by giving milk into the mouth, we line from the mouth all the way to the gut. We increase the good bacteria that live there, creating this barrier, a healthier microbiome, calming inflammation, and making it less likely that the body will react to a food protein later in life. So, the key takeaways from my talk is that taste and smell is a really cheap and easy intervention to provide. It can be given anywhere from low to high resource settings. We know from qualitative research that we've done that when babies are admitted to our neonatal units, the parents feel a real disempowerment. This mum told us, I felt I had no control. So by being able to say to the parents, well, you could provide your baby with a taste and smell of milk before tube feeds, it has the potential to give them back some of that power. And then to also be able to say to them, that may even have the potential to improve your baby's neurodevelopmental outcomes, just adds to the benefits. That's me. I'm going to hand back to Frank.
So I'm just going to wrap up and be the other end of the bookend and tell you a little bit about what we are now doing going forward. First, we have used the information from these two trials as well as much other information that we've generated both within New Zealand and internationally to develop some consensus national nutrition guidelines, the first national guidelines for neonatal nutrition in New Zealand. And we have done this with collaboration throughout the country. We've had participants from all around the country's neonatal units helping us develop these guidelines, some of whom are in the audience today. And these are particularly important because you saw in Barbara's talk the difference in outcome between hospitals based on different nutritional approaches. And we hope that by introducing a national nutrition guideline that will be released later this year, that we will be able to standardise approaches based on evidence that will improve outcomes around the country. Secondly, we have some more big questions that we're trying to answer. We were fortunate enough to get a new Health Research Council programme grant at the end of last year, and this is what we'll be answering through that grant. First, we're going to bring the Diamond Trials babies back, or there'll be children now, at school age, so that we can generate the first data for New Zealand on school age outcomes for moderate to late preterm babies. And this will include MRI images of the brain to investigate potential mechanisms. And we have some preliminary data, again, showing changes in early life in these babies. Secondly, we're going to be asking the question of how much and which vitamins the preterm babies need. We haven't talked about that today, but all of you will be aware of how important vitamins are. And the vitamin preparation that we use in babies is 30 years old, wasn't designed for babies, and has just been transferred from older children or adults. And it's completely unfit for purpose in that we can't give the right balance of different types of vitamins through that preparation. And finally, we're going to follow up on the studies that Barbara was talking about, really investigating why does low phosphate in these preterm babies lead to poor outcomes. We're particularly interested in whether it's related to immunological function. And so this will be a laboratory study led by Associate Professor Gergely Toldi, also from the Liggins Institute, investigating carefully how different levels of phosphate in the blood will affect immune function. And hopefully, when we've completed this, you'll all come back and hear how we got on in a few years' time. I just want to finish by thanking many people who have made all this research possible. Rather than put all the names down, I've put down the trial groups here. We work very collaboratively in the Liggins Institute, and there are numerous people involved in all of these studies. So there's the Provide Trial Study Group, which included the other hospitals in the country, as well as members of the Liggins Institute, and of course including the follow-up team, to which Tanith and Barbara referred. The Diamond Trial Study Group, similarly, a large number of people. The Human Health Research Services platform, which is based in the Liggins Institute and includes the follow-up team. And then, of course, the funders who supported this work, the Health Research Council of New Zealand, that funded both of those trials, along with Counties Manukau Health, Cure Kids, Lottery Health Boards, Kelleher Charitable Trust, A+ Trust, and Nurture. So a combination of government funding and philanthropic funding that has supported this work. So thank you all very much for your attention. We're happy to take some questions and also happy to talk to you outside afterwards. Hope you'll stay and join us for a glass of wine. Thank you very much.